I would say, I'd like to say the second annual, because I think this happens about once a year, when Durhan Wong-Rieger talks to Jackie Manthorn of the Canadian Cancer Survivor Network, because both CORD and the CCSN are real leaders in helping get people around a table and talk about some complex issues. The CCSN, as some people in the room know, how many of you have actually participated in a CCSN webinar? Good. I see some people that are actually writing and some questions. So I'm often hosting them, or other of my colleagues at 360, among some other people in the room here. And it's a really good system and opportunity to have a broader reach beyond whomever is just in a room or in an individual consultation. And so last year, or maybe it was the year before, we had a power panel. We did a 1.5-hour webinar from one of CORD's conferences that turned out really, really well. It was an excellent conversation. And so we thought this year, with some of the discussions that are happening on several big issues, starting from the May 16th Health Minister announcement in Ottawa, but also what Minister Hoskins in Ontario had announced just a few weeks ago, before that actually, which was the introduction of OHIP+. So we thought, bring the two groups together once again. We'll do a 1-hour live webcast of the level-setting discussion on OHIP+. And then what we'll do is we'll turn the webinar off, and we'll have the discussion in the room, actually with some people from the Ministry of Health and Long-Term Care. Once we've talked through some of the themes and some of the considerations that we're going to so ably learn about from our next couple of panelists. So I'll let them introduce more about what they do and the perspectives that they bring, but leave it to just the point that I have known and worked with both Chris Bonnet and Nigel Rosina over several years now, and have great respect for their analytical capacity and their search for the best solution given a certain situation. So I can't think of anyone better to kick off this discussion of what we know about OHIP+, which is relatively little, and then applying it to what's actually working out there in Canada across the jurisdictions in terms of access to pharmaceuticals for children already. So with that, I'm going to invite Nigel Rosina up to the stage to walk through his perspectives on OHIP+, especially from a drugs for rare disorders perspectives, and which is really important for CORD. Over to you, Nigel. And just a quick sound check and a reminder to those on the webinar. I would encourage you to remember that you can ask questions. So ask the questions as you're going through, but we're going to get to that in about 15 minutes towards the end when we have a panel. So over to you, Nigel, and thanks very much for everyone on the line and in the room. Yeah, you're just going to use the arrow down. We're not going to show it as a screen, but we're sharing screens.
Okay. So thank you, Bill. And thank you for inviting me. He says to use the arrow down, and it doesn't. So
I'll just click in here. Now you can use the arrow down.
Cool. Except it starts in the middle.
It stops in the middle. You should have 3 in the middle of yours.
Mm-hmm.
1, 2, 3. Oh, your conclusions happen too quickly. Sorry, we're going to go to another window then. Let's just go right from here.
Well, maybe all you want to hear is the conclusions anyway.
There you go. Plan B. Over to you.
Okay. So,
you start with a bit of your background, and then.
Okay. I'm Nigel Rosina. I'm an epidemiologist. I've looked at drug safety for many years, which is probably my big interest. I certainly worked in academia for many years and in industry, both in, well, in the UK for many years, here, and for a brief period in the States in a large health insurance company. So got some experience of different, certainly different pharmaceutical cultures and environments. As I've moved into semi-retirement, or at least that's what I say to my wife, who says which is the semi bit, I've become interested in more sort of some of the health policy issues that we have in this country, and this is one of them. So, I was looking at OHIP Plus and was considering the affordability of rare disorder drugs. And one of the things, I mean, we often see this kind of thing that comes out from the newspapers. I noticed it from last month, where a mother was very concerned that she couldn't afford the drug, basically. So are these the sort of parents that OHIP is going to help? So I then sort of went back to look at what the government says about OHIP Plus, and our esteemed Premier said that we're making sure that every young person across the province has access to medications they need to stay healthy, etc., and that they're easing patients' worries. In the same news release, Minister of Health Hoskins said that access to medicines will be improved by eliminating financial barriers to prescribe drugs. So this sounds good. This is kind of the thing that maybe this is going to help these parents. But then you read it's going to be covering only drugs that are in the formulary. And the formulary in this province has three kind of lists. The general benefit list, which is the unrestricted use list, and I went and looked at that. It's online. There's almost 4,000 excuse me, 4,000 products in there. And when I talk about a product, it means that one product would be a company's A's amoxicillin 20 milligram tablet. If they make a 40 milligram tablet, that's another product. And so basically that's what I mean by product. If you actually sort of filter it down, you end up with quite a lot less product, quite a lot less. And for 3/4 of those, ODP, the drug plan pays less than $1 for each of those pills. And so basically they're paying for relatively low-cost generics. Very few cost more than $100. There's a limited use list, and in other provinces it's called special access and all that sort of thing. It's about 940 drugs in this province. And again, although they are disorders that the drugs that are limited to specific disease characteristics in patients or a defined period of treatment time, they're actually, in general, the amount that ODP pays is not that much. And then the third list is the Exceptional Access Program. Not every province that I'm aware of, I think this is probably the only province that I'm aware of, has this additional program. There's 127 products on that. They're detailed. They have frequently complex access criteria. About 25% are actually drugs that are already on the other lists, but for very specific use. About another 25% are oncology drugs. About 10 to 11% are hepatitis B, hepatitis C type products, and the rest are a mixture. But many of them are biotech products. They're often expensive, but then this is the only list that the ODP doesn't actually say what they're paying for those products. So the drugs most commonly dispensed that I could find to children and to young adults are obviously antibiotics, anti-asthma drugs, attention deficit disorder drugs, and then some different drugs here. Most of these are generic, most of them available at a reasonable cost. So the additional cost to the drug price is going to be relatively modest. So then I thought about, well, rare disorder drugs, and some of you may have seen Cadith published an article at the end of last year where they looked at submissions for rare disorder drugs that had gone through the CDR between 2004 and February 2016. So I looked at that list. I had been looking at it for other reasons. 19 of those submissions were for 16 drugs for rare genetic conditions. So I was trying to look for conditions that would likely manifest in childhood. And 13 of the 19 received a negative reimbursement recommendation. Since Cadith, the data was published, 2 of the drugs have actually had a revision in the CDR assessment from negative to positive. And when I say positive, I mean positive with listing criteria, with economic criteria, or both. And so now 8 of those submissions now have a positive recommendation. And that's 42%. That's not bad compared to the CDR general rate, which is sort of 50 to 55%. But you've got a very specific group here. So I took a look at those, and I'm not going to go through these in detail, but these are the first 9. They're all lysosomal storage disorders, which basically the body basically can't get rid of toxins, and that produces a negative effect. You can see here that some of the drugs overlap in terms of their disorders, and you can see that with the revision for Vimizim to a positive recommendation, that 3 out of the 9 have received a CDR reimbursement positive recommendation. None of them are on the ODP listing in any form that I could find. The other 10, better than that on mine, are a mixed group. Kalydeco for 3 indications for specific mutations in cystic fibrosis. They all had a positive recommendation from CDR. One of them is on the Exceptional Access Program, which is the product that, for those who know who Maddie Vanstone is, was the one, was certainly a great advocate for that, forcing previous health ministers to stand there and try to explain why they weren't funding it. Afinitor for 2 tuberous sclerosis complex associated non-malignant tumors in the renal, in the kidneys and the brain. They both were negative, but they are on the EAP list. Dravet syndrome is a very severe form of epilepsy. That was given a positive recommendation. It's also on the EAP list. Kuvan was the other drug that received a change in the recommendation from CDR to positive. It's on the EAP list, and I'll say a little bit more about that. And the other 3 drugs you can see here all received negative recommendations, but one of them is on the EAP list. So listing doesn't necessarily mean access. We heard that this morning. We know that. So I did talk to some of the patient advocacy groups, and thank you for some of them are already here. So this is my interpretation of what I heard. So forgive me if I'm not totally accurate. But for Kalydeco, for that specific gene mutation, and for diacomet, access is usually reasonable. The CDR recommendations are not the raw requirements, or the criteria are not particularly extensive, and they are attainable. Afinitor, which for the tuberous sclerosis complex non-malignant tumors, are, my understanding, reasonably accessible, but in general most patients are required to have a surgical approach in the first place. And surgery is not without risk. We're talking about kidney surgery, brain surgery. So when we all know that surgery, I don't know if anybody has ever worked with a surgeon, but they always have high opinions of themselves, and there's no risk in surgery, but there is a significant risk in surgery. Yeah, I've dealt with those. Kuvan. John Adams will tell you that the criteria that we have in this province is so harsh that no patient is yet to have access. Maybe that's going to change, but so far, and it's been on that list for a while. And Soliris for AHUS is usually reserved for acute patients and those who've had a kidney transplant. Certainly in the wider population, whether that's true in the children, I'm not totally sure. So, there's variation in changing from listing to access. I did briefly look across the provinces, and anybody who's tried looking at the various formularies across this country, it can quickly drive you up the wall. And you can see that basically Kalydeco for the G55-1D's mutation has some reasonable access, or at least certain provinces. There's more provinces with it listed, and diacomet similarly, but the rest are pretty spotty. and some provinces clearly don't have any. And I should say that this is really what's accessible in terms of a public plan, publicly available information, I should say. If there's sort of private agreements that are not transparent, I don't know about them. So what can we conclude? Well, the former is chiefly limited to lower cost generics. I mean, that's quite clear. So children with common conditions who have parents that have no current, they either don't qualify for provincial aid already, or they have private coverage, are certainly going to benefit most, in my opinion, from OHIP Plus. The children with rare genetic disorders, to benefit much from OHIP Plus, even if they're on there, and even if the products are on there, they get access. The coverage will stop at the age, well, certainly by the reach 24, 25. So what are they going to do then? Are they going to move back in home and expect the parents to pay for it? What are they going to do? So one last point that I think is particularly critical, and that is whatever OHIP Plus eventually evolves into, in my opinion, the advocacy that that many of you patient groups have been doing is going to still remain essential. Thank you.
Please. Thanks very much, Nigel. So I would invite Chris up to the podium. Let's go back to the original webinar. There you go. So we're going to use the down button to advance. Yeah, please. Okay. Just mind introducing yourself and then jump in.
Good afternoon. And first up, I want to obviously thank CORD for the opportunity to speak today. It was an interesting challenge to go dig into something for which so little is known and try to make any sense of it at all. So I also want to applaud Nigel for trying and beginning to make some sense of this, to figure out what it is and what it's not. My job was a little different, to look at how children and young adults presently access drugs in this province. And by way of background, I'll mention that although I'm migrating more and more into policy discussions and investigations, primarily in the place where private insurance and public insurance meet in the drug world. My background is in private insurance, many years there in different roles, and so you'll see possibly a little bit of a bias in some of this information towards what the private insurance industry, which includes employers, which includes pharmacy benefit managers, are likely to think of this program. So let's begin. In about 10 minutes, and I'll do a time check right now, we're going to look at as much as I could find in short order around where drug coverage exists across Canada right now for children and for young adults. I've tried to provide some estimates of the coverage in Ontario based on what I could find. There's not a lot, but I probably missed some sources. Even some things came to me earlier today as I was listening to people in the morning discussion. Tried to identify, like Nigel and complementary to Nigel, not only what drugs would apply to children and adolescents, but what therapeutic classes and where they rank according to one of the major pharmacy benefit managers in Canada. Some considerations and questions, and it's only a starting point. There are many, many more. And then some conclusions, hopefully, about how on earth we do pay for drugs and what benefit OHIP Plus is likely to have on that picture. So this, to put together this slide, which looks at special drug programs aimed at children and young adults in the provinces across Canada. The territories are not included here. That was for space and time reasons. You'll see the citation at the bottom. Without this study, I would have had to do a lot more work to pull this up, and it is in small print, but it is there for people to reference. But I did go back and check most, if not all, of the government websites just to be sure that this information was current and to get some additional clarity. So as you look at this, what you'll notice, a couple things. BC and Quebec have no child-specific or young adult-specific programs in place, and there's reasons for that. One of the political and policy decisions is whether or not you have a universal kind of plan. Well, both BC and Quebec do, although they're very different. Obviously, Quebec's being a social insurance model, BC being mostly a catastrophic model, but defined rules for private insurers, defined rules for the province, and out-of-pocket payments for most plan members, most patients, although there are significant and generous subsidies available, I believe, in both provinces, but certainly in Quebec. So that's one of the things you notice out of this. The other thing is you'll notice that sometimes, one province in particular, for their child and young adult programs, they will target specific low income levels. And that income threshold, $26,000 in 23, is for parents, single parents with one child, and the dollar values increase as children and number of dependents go up. So for space reasons, you just see the starting point here, and you'll see that there's a hard cap on that. It can be age 18 if you're no longer in school. It can be age 20 if you are in school, and then that child health benefit will continue to pay. So that's the Alberta approach. Then you'll see across the board different age limits in place. Sometimes a young adult is, sometimes the coverage is bounded by the turn to adulthood at age 18. Sometimes coverage goes to 19. Sometimes it goes to 25, sometimes 26. And so it goes. It's all over the map. There is very little consistency. The other thing you'll notice is that child programs focus on certain areas, and you'll notice insulin pumps across a number of the provinces, growth hormone deficiency particularly, and I think specifically in New Brunswick and in Prince Edward Island, there are programs there, and there are childhood immunization programs in Prince Edward Island, and I believe in other places sometimes this is limited by the level of detail on the websites. So this is what we've got, and it is to say that it's all over the place, but it is to say that the Ontario OHIP Plus plan is unique. It's unique in that it is universal for all children under age 25. It's unique in that it's a combination of ODB and EAP drugs, and it's unique in that there is first dollar coverage and no caps or limits on that. So that's in some ways better, but at the very least you can say it's different. And we'll come back to that. This is a whole lot of numbers, not because I want you to focus on them today, but I thought it might be helpful, and it helped to sort of frame my thinking a little bit if I started to look at this. So I pulled information from different sources. Again, those sources are noted here to try to figure out where we're starting in terms of government drug spending for ages 0 to 24 right now. And best I can guess is of 2014, Ontario spent about $146 million. You'll know that the announcement talks about $465 million, a number that nobody so far can explain or support, but it's as good a place as any. And so you'll see that there's a fairly significant incremental spending of about $300 million here. You'll see, if I take you around to the sort of 2/3 of the way down, currently by the ODB 2015-16 report, there are about 400,000 children and young adults that are paid for now by OHIP, and that number, of course, is supposed to rise to 4 million. So we've got roughly 10% of the total eligible population covered right now. So that's a very different number when you were going from 10% to 100%, and it involves, of course, 3.5 million additional beneficiaries. But it is very hard to tell how much those beneficiaries are going to cost. And at the bottom there, I've just noted where, according to the ODB anyway, where the coverage comes from this day and age. You'll see, obviously, their programs pay for almost 1 in 3 Ontarians. Other public programs, that would be maybe federal programs, are covering about 2%. Private insurers, a little over half. And they've come up with a number of 16% for uninsured. Again, there are no data, no current data in my mind, to my knowledge, that explain or really explore the number of uninsured or underinsured. Just because you have private insurance doesn't mean you have adequate private insurance, particularly when we're talking for about very expensive products. So the bottom line is actually the top line. The public side at this point, it's very unclear where we're starting from, and but this is just a snapshot of available data sources. But as bad as it might be to figure out where we're starting from on the public side, it's maybe a little bit more difficult on the private side. What we can say in general terms is that the top bullet there is generally how private drug plans describe coverage right now for children and young adults, generally to age 18, except age 23, 25, could be 21 if you're a student, and a student can be college, university, or some kind of private post-secondary institution, many plans will also allow that if that dependent is physically or mentally incapable of self-support, the age boundaries no longer continue. Most private plans are still reimbursing 100% of the eligible cost. Now, by most, I mean about 40%. Best data I can find, and again, there's no industry data to help in that. Other common reimbursement levels are 80% or 90%, and by then, you've covered probably 80 to 90% of the different reimbursement levels across 125,000, and again, we have only approximations, 125,000 private drug plans that are offered through about 24 private insurance firms and others like Green Shield that is not actually an insurance company but has a very important market share. We don't know the current drug spending across the industry. There are no data for that. And those data, to my knowledge, are not reported to CIHI either, so the NHEX National Health Expenditure Database is no help there either, certainly not when we're looking at province-specific information. TELUS Health helps us a little bit, and I have gone to them for more information, but none was available as of today. About 31% of claimants aged 0 to 29, again, not quite the age band we're looking for here, but as close as I could come, account for about 12% of total eligible costs. So the numbers are unimportant. It's really the premise that this is a younger population, is generally a low-cost population, and for private insurance, that also means those younger people are subsidizing the costs for older people in that workplace. So because younger people are there paying premiums, it means that older people and less healthy people pay less. If we take out the younger people, it may mean that the total premiums go down for the employer. I'll talk about that in a moment, but it may mean that premiums per person go up because our spread of risk is diminished and because the people that are left are statistically more likely to be incurring costs. Again, best guess from the early commentaries is that OHIP Plus may save employers between 8 and 11% of their drug claims, and it may help them feel better that they can defer anything else they want to do to control the cost of their drug plans. Thank you to the government for saving our bacon one more time. But these are approximations, best we've got at this point, and there are differences according to the type of plan you have. If you have an ASO plan, in other words, you're a large employer and you self-insure that risk, you will see that benefit immediately because you're paying for your claims month by month. If you're a smaller employer, you pay a set premium a year in advance, and it's maybe a year, 2 or 3 before those costs come back in terms of higher or lower premium costs. So the mechanism here is different by employer, different by plan design, different by funding mechanism. Again, it's hard to be very specific at this point in time. With appreciation to Express Scripts Canada and the excellent work that they do in their drug trend reports, this is my best guess, non-clinician, non-expert, to say, well, what are the therapeutic classes that may impact children and young adults? So these are drawn from the latest Express Scripts Canada report. You'll see a lot of expected things like diabetes, depression, which of course manifests itself very frequently in the teenage years. Infections has been mentioned, cancer has been mentioned, and then we get into more expensive conditions like multiple sclerosis, rare diseases. We had to put that in there, but fortunately there was a number in the Express Scripts report, and cystic fibrosis. So the average cost per script that they reimburse, that's noted here. You'll see wide variations, some lower cost products. This is per script, not per year, and there's an assumption that most of these products are going to be ongoing use, often over years, with the possible exception of infections, which mostly are acute. And you'll see various notes that I hope would be useful to put a little context around each of these classes. Some of them have extraordinarily high year-over-year cost trends, which maybe are the scariest ones because, as has already been mentioned, employers and insurers like predictability. And if you're racing ahead at 14% or 12% or even 42% when you get into drugs for rare disorders, that's a scary and unpredictable number for employers, and there could be some consequences that arise from that as they start to think, is this drug plan affordable? Is this drug risk manageable? Do I have the expertise, skills, and budget to be able to continue in this? Some general considerations, and I'll start by prefacing that with everything that I've read, it's not entirely clear to me what the purpose and goals are of OHIP Plus. That hasn't been clearly defined. So if we're going to measure, do we have a successful program here? I'm not sure how we do that without a starting point of what problem are we trying to solve? What is the issue that we're trying to address? And over some period of time, then can we measure levels of success against those stated goals? One of the interesting things, and I think this has already been pointed out by Nigel, is that the written information on this is a little bit all over the map. The budget document itself talked about paying that OHIP Plus would address those most in need and least able to pay. But for a lot of the reasons that Nigel's already brought up, it's not quite clear that OHIP Plus is going to do that. And in fact, that objective seems to have kind of merged and morphed into other things as more communication has come out. And I'm sure we haven't heard the last of that just yet. So as I mentioned at the onset, there's no detail, there's no certainty in terms of estimated costs or what assumptions have gone into $465 million or more. If we look at some of the private plan data and we look at the roughly 1% of private drug plan members who spend $10,000 or more, when you spend $10,000 or more, on average you're spending about $26,000 according to the Express Scripts report. If we're talking about going from 400,000 people to 4 million people, and we're not quite clear about, if we have 1% of 4 million, 40,000 people, let's say those 40,000 high-cost members of that young and young adult cohort spend $20,000, we're talking about $800 million already. So again, where does 465 come from? It's not clear, and it all depends on what assumptions we make about the risks that we're covering, the prevalence of high-cost drugs in that mix, whether OHIP Plus covers them, maybe not, probably not as it's formatted or presented right now, but the numbers again are all over. It would be really nice to get clarity on that, and we have about 7 months to do that. 6.5, I suppose, at this point. So that's a challenge. Impacts. There are several. Let's get into some of the private drug plan impacts. Well, as I said already, if you are a small employer and an insured plan, you aren't going to see the benefit of OHIP Plus right away. Your insurance company is not going to give you an 8 or 11% immediate discount. They're going to wait and see how the claims come in. And as you can imagine, there's many other things that are going to affect your claim levels than OHIP Plus. So all of that has to be factored in before an employer actually sees a benefit to it. And if it's 2 and 3 years down the road, it's going to be very difficult to attribute a reduction or lower increase to OHIP Plus versus anything else that might have affected your drug plan. Young members are already low cost, generally speaking. That means the risk spread changes. As I mentioned, the rates may increase for older people. A knee-jerk reaction on the small and mid-sized employer market without some deliberate communication by government, insurers, and others as it comes available is they may simply exclude people under 25 because OHIP covers them, right? OHIP Plus covers them. We don't need to do that anymore. But as has already been clear from Nigel's comment, well, there are many drugs that won't be covered by OHIP Plus if the knee-jerk reaction is simply to eliminate coverage for young adults and a claim comes in. What does the employer do about that? Oops. A major employee relations nightmare and potentially a media nightmare when some of that comes into a headline news story. And unknown future costs. Employers like predictability. Well, what if this is more than $465 million? What if it increases faster than expected? What if it's less? We don't know. But if it was more, the employer health tax is already a dedicated payroll tax to employers that it collects almost $6 billion already in Ontario. That's the projection for this current fiscal year. What about a 10% increase to that to pay for this plan? That's conceivable. Who knows where that's going to go, but government has budgets to balance, and that's obviously one part of their election platform as well. So here's some general conclusions. There are, just to start, some general ones around philosophical. What are we trying to accomplish here? What is the policy goal? What is the public and the societal goal that $465 million justifies? And what's the opportunity cost of spending that there? To Wayne's earlier point about take-home cancer drugs, oral cancer medications, what could we have done differently with $465 million that might have solved a different and very real problem? And then there's the practical elements about how does this get implemented, consultation, and so on. So my conclusion is that OHIP Plus is the design that's been expressed so far is certainly unique in Canada. Other provinces shoot for different things, either low-income residents or certain key diagnoses. Some have co-pays, although those are limited. And the other model is simply let's do it in a consolidated way, as Quebec does, with a consistent level of coverage for everybody covered under a government plan. The budget, as I mentioned, speaks to addressing the most vulnerable among us. But then the message changes in some of the content to things about equity and fairness and so on, and supporting the notion of universal pharmacare, all worthy objectives, but longer term as opposed to addressing an immediate real need for a certain segment, undefined, of our population. So what is that immediate purpose and what are the long-term goals? And they should be made clear. We have, I think, an expensive new program that's probably a little more complicated than we might imagine to implement. How long is that going to take? Does that mean that there's an opportunity for engagement, input, consultation? Not quite clear about that. And it could be that because we need all hands on deck to put this in place, that there is an invitation to get involved with this. It also might mean that if that deadline is tight and that election is driving some of this decision, the government may just say we're going to put it in and we'll fix it afterwards. Who knows? In general, for the employer community that pays over half of the insured drug costs in this province, it's a welcome surprise. The biggest impact will be on the larger employers with administrative service only plans, uninsured plans that have large recurring claims. This is a big and important development for them. 8 to 10% of hundreds of thousands or millions of dollars of drug budget every year is important money. But if employers choose to eliminate coverage or restrict coverage for those under age 25 as a result of OHIP Plus, that is obviously a negative and unintended consequence of the government and I think of all of us if that's the reaction. So I hope that helps sort of fuel some discussion and is a compliment to some of the good work that Nigel's done in sort of floating other important discussion points.
Thanks so much, Chris. And I think we should, after this, we're going to go back to that question slide that Chris, you had up. So that was excellent. So we're going to pass the microphone over to Durhan, who is going to talk about what patients are saying and maybe give a bit of a reaction to what she's heard. And then we're going to have a panel discussion. So over to you.
Thank you very much, and huge thanks certainly to Bill for setting this up for us, and huge thanks to Jackie Manthorpe with the Canadian Cancer Survivor Network. I think it's been a great collaboration for us in many respects and be able to do these kind of webinars, and we appreciate your taking one of your sessions to allow us to have this joint discussion and have a broader engagement on this issue. Just to say that I'm just going to do two very quick things because I do want to get into the discussion. So most of you will know is that I'm President and CEO of the Canadian Organization for Rare Disorders. We are certainly, I think, very much, wanting to be involved and appreciate the opportunity to consult on OHIP Plus going forward. It was certainly a surprise to us when this was announced. But at the time that this came out, we were at court in the process of actually doing a fairly wide patient survey on a slightly different issue, on a very different issue actually, on biosimilars, which went out beyond certainly the rare disease community, but to a very large patient audience, and more than 2,000 patients on our list. And so we took the opportunity to add on to it just a quick question around OHIP Plus and how patients felt about it. So I'm going to just give you some real quick highlights from the results of that survey. And it may be a little bit different than what you've heard so far. So this is, right from the patients directly. The first question we asked is, to what degree would you agree that OHIP Plus is a very good initiative and that it will in fact benefit Ontario patients? And slightly more than 50% said yes, we agree. And we kept it very simple, so it was a pretty binary kind of question. Only about 13% said no, we don't, and about 35% echoing some of what you've heard says we're not real sure, we need to see more detail. So that was actually very interesting. So on the surface sounds good, but there is a huge amount of uncertainty in terms of what it really means and how it's going going to roll out. We also asked this, what do you think about, in terms of private coverage, though, which usually tends to be quicker, is this going to be a concern in terms of getting drugs in as quickly as possible? And about 2/3 said yes. This is an issue that we do expect that if we're going to have something like OHIP Plus and it's going to be first payer, that we need to have them move as fast as the private payers in terms of being able to bring access quickly. Only about 3% said no, we don't think this is a problem. So I think a quarter said we're not sure. We'll have to wait and see the details. So there is some concern around how quickly this is going, actually how this is going to turn around. We also asked, and I think it was the question that Chris was addressing, what about universal prescription drug coverage? Is this something that should be available? Is this an important first step to it? And interestingly enough, more than 70% said yes. We would like to see universal prescription drug coverage in the province, and that we believe this is a step toward it, and if this is a step toward it, we would support it, without any real details, obviously, in terms of what that would look like. Again, only about 3% of people said no, and about a quarter said, we need to kind of wait and see kind of what that might look like. We also asked the question as to whether or not, this is sort of was a giveaway, do you think that patients and healthcare providers and other stakeholders should be part of the implementation process? To what degree should we be involved? And of course, about 90% of people said yes, we definitely need to consult with the patients, consult with the healthcare providers in terms of implementing this and in terms of the details. So we really do appreciate the fact that we've heard back, certainly from Ontario, that there is in fact some real interest in terms of helping to fill this out. And finally, we asked the question as to what degree do you think this might actually put some of the private payer coverage in jeopardy? Is this going to be an impact? And only about 15% said we think this is going to be a real negative impact in terms of private plans. So again, we didn't offer any details. To be honest, most of the people, more than 50% of people said we have no idea. We don't know. We don't know where this is going. So I would say overall, patients are very optimistic about it. I think there is some uncertainty in terms of where it might go. I think what most people are seeing it as a step towards a much more universal coverage. I will tell you some of the comments that we got back, which were very important, and certainly in the rare disease community. A big concern that the rare disease patients are having is the private drug coverage is not covering everything. And there's a big concern with regard to deductibles. So the idea that we could have a plan that would actually offer no deductibles, offer no copay, I think this is something that is very, very important, and there's no income-based biasing on it. This is very important because what we're seeing is that the private plans are actually backing away from this in terms of. The other issue we had raised over and over is that, quite frankly, there was lots of concerns with the fact that as you move from employer to employer, as your private plan may change within an employer, your coverage is not guaranteed. So there's a lot of uncertainty among patients, and certainly parents who have children who have expensive drugs who are very concerned about the fact that because I got coverage today does not necessarily mean I have coverage tomorrow. So even if this were to provide a much more of a leveling process to force everybody to be able to cover it, they would see this as very, very positive. So in many respects, I agree very much, I think, with what Nigel is saying. We need to see what drugs are going to be in there. We need to make sure that the drugs are going to be adequately provided for in there. And that might mean stepping up what we have. But on the other hand, if it's going to provide people with certainty around being able to have continued access to these drugs and without the concerns and the worries about the deductibles or the copays, I think this is something that people would see as very positive. So that's where we're going to leave it at the moment.
Okay, so I'm going to check over and see how many people on the webinar actually have some questions and open it up for audience discussion as well. So there is a floating microphone right there. Maybe Ian? Thank you very much for offering to do that. I've always told you. Thanks. So maybe the first thing I'll put to Durhan is did the survey results actually inspire you to have this conference and to kick this off? And because I was just going back to the theme earlier in the day, and the questions about OHIP Plus, it's how do we make sure OHIP Plus is an actual plus, that it is the best plan possible. And I think that's what we're going to go into small groups and talk about. But is that where you started to make that connection to say we got to do this right?
No, it didn't come out of the survey, quite frankly. I think the minute we actually had the discussion with Minister Hoskins, and as he was announcing it, we really wanted to have assurances that we could have input into the plan, and we thought the best way to do that was actually bring in stakeholders and have that discussion. But I will say is that some of the comments, and certainly this morning as well, but both Nigel and Chris's comments have helped to raise, I think, some very important things that we want to make sure are in there. And certainly, I think, as Nigel kind of said, you know, what was the problem and what is it we're trying to fix? So some of the things that I raised in terms of some of the cracks that patients are falling through, even with the private coverage are it, but we're also very concerned that if in fact it means that monies that could have gone to bringing in drugs that are not currently covered, and certainly less than half of the drugs that we have for not just rare diseases, but therapies are not covered. If that is going to be an issue, I think that's something very important to discuss. What would be, you know, talk about opportunity costs. Where should we be putting that money? And I think it's worthwhile having that discussion. But I think we will take a leap of faith and say that the minister's intentions were to try to improve the coverage to all patients. And so how do we make sure that that's happening in terms of both the breadth of the drugs coverage and in terms of all the patients?
Well, no, you're spurring the conversation. Do either of you want to react to what Durhan's raised just now?
I'll just say that there are a number of drugs on there that have received a positive recommendation from CDR, and so why isn't the drug plan reacting to that and actually putting them on there? I agree. I think that the minister has good aims, but as we've heard this morning, I think the same sort of plan occurs here, that it's sort of terribly difficult to get hold of what they actually plan to do. So it's difficult to react to it.
Maybe to what Durhan was suggesting earlier, though, the fact that they don't know, and we've got about 7 months left before it's actually implemented, forums like this are an opportunity to raise some of these considerations and perhaps to look at how things are being done elsewhere. Well, two things. One, Chris, I've put your questions and considerations up. I'd like to open it up to the audience here as well, and to remind people that we're going to actually have more time this afternoon to unpack this. The opportunity here was really to get some level setting. Chris, have you looked anywhere globally? You did a great, not that we want you to go off and do more work necessarily,
but maybe.
But in your search for what's going on in the other provinces, did any other jurisdictions outside of Canada really strike you as opportunities to really look at for Ontario as they go forward? And maybe that's a question back to Neil from earlier in the day too, who spends a lot of time outside of Canada. For your perspectives on OHIP Plus, I think that would be great. So,
I would say that in looking around and doing a very basic search, there are surprisingly some American models that are out there that could be useful. What I recall is some Blue Shield, Blue Cross types of children-specific models, but I didn't look into them in any detail. I think the comment that I made about Quebec as a universal system applies to most European markets as well. Whether it's a single-payer system, which I guess you could say the National Health Service in the UK is, or it's a social insurance model as is in Germany, the Netherlands, France, coverage is universal. And so children are not as precious as they are. I think of all those bumper stickers I see about baby on board. They're not all that's important, and yet other countries have done a better job than we have so far at establishing a broad-based, universal, consistent coverage where notionally nobody obviously falls through the cracks. So there are different strokes. That's the other thing. There's no one model that solves this problem, and it's not to say that OHIP Plus is wrong. It again comes back to what goals and objectives the government has, and I think relevant to this group, how amenable it is to inputs on that to target and focus it so that they can pat themselves on the back in a few years, say we did a really good job on this. It actually addressed an important need, and it was an important need that we could identify and then build in measurements and evaluation systems to say, hey, we're better off now than we were before if we're spending $400 or $500 million.
Well, I think the minister is hoping to do that in time for next year's election, if that's possible.
I don't think that's possible. Yeah. But
Neil.
Yeah, thanks, Bill. I guess in some of the other countries, most other countries have some form of co-payment, and so this notion of first dollar coverage is in some bit foreign. Excuse the pun. But what they do in some of those markets is that children would have, or the pediatric community would have no co-pays. So that would be sort of the approach they would take in some of those markets. But generally, as Chris was saying, that there's not much of a distinction between adults and children. There's coverage for everybody, and whether it's all public or public-private or whatever it is. But generally, it's the co-pays that would be forgiven. And since I have the microphone, I can jump in with another comment. What strikes me about OHIP Plus, I think the goal of providing people under the age of 25 with coverage is wonderful. But if we assume, for example, that, say, 75% already have coverage somehow, people in college, university have it automatically, and the rest of the parents.
A little louder.
Yeah. Sorry. If we assume that 75% of people under 25 have coverage somehow, the ones that don't have trillion for catastrophic, so we're really looking at everything up to catastrophic. It seems to me we're spending $3 for every $1 benefit, which to me is an incredible waste of money if you have scarce healthcare dollars. If we have 465, almost $500 million, why not spend it? Why not make Ontario the last payer, in other words, where there is no coverage, and then spend the remaining $300 million on oral cancer drugs, on lowering the threshold for trillium, on orphan drugs that are not being covered, as opposed to providing coverage for people that already have it. That's my editorial.
Thanks very much, Neil. And the rare disorders community applauds your suggestion for shifting budget in that direction. Dennis, the microphone's here. And then did I see a hand over here? Yeah.
I'm not sure the microphone works.
Oh, thank you, Kim. Yeah, you just pull it closer to your mouth, and certainly because this microphone, my big microphone up here, has to pick it up as well.
Okay, how's that? And it's for Nigel and Chris. Is there anything we could possibly do to make our system more convoluted and complex?
Yeah.
What do you have in mind?
Yeah, my answer would be yes as well.
So, Kim Steele.
Hi, thanks. And one comment and one question. The first comment is, Durhan, everything you said about private insurers, one of the challenges we're facing is cystic fibrosis with high-cost medications is that people are hitting their lifetime maximums after 1 or 2 years. And then where do they go after that? Because none of the new medications are covered by provincial plans. Certainly Orkambi isn't. Question is to Nigel. Nigel, you mentioned in the CADF report on rare disorders that 2 medications were reconsidered and subsequently received a positive recommendation. Do you have the details? I haven't read the report, so I'll start with that. Guilty. But do you have any details on what brought the change of mind? Was new evidence brought, or what was the decision-making process like?
It's a good question, and basically I can't remember. I think there was some new evidence, but if I'm really honest, it's a while since I looked at those reports. So I'd have to get back to you on that.
So yeah, I think in both cases there was new evidence and certainly some new cost health economics evidence that went along with it, but definitely it was a resubmission based on more evidence that was collected.
Okay.
And John, you might have some more insight here.
Having one of the molecules involved is my favorite molecule, but they're both, ironically, both those molecules which got revised position are from the same small manufacturer, Vimizim and Kuvan, you can say yes, there was some additional evidence, yes, some additional analysis, but I think it had to do with some persistent advocacy over time in softening up the system for those responses. I think also the change in classification schemas as to how CADIF and CDR make their recommendations. They in effect abandoned saying no for reasons of price. Right? And said, well, we got PCPA up and running. The price issue is fundamentally a PCA problem, not a CDR problem anymore.
Thanks very much. We have about 5 minutes left on the webinar, so if there are any questions that people have on the line, please feel free to type them in. And just to remind people who are delegates here that the conversation will continue. We're going to turn this off. So if there aren't any other questions, oh yeah, Ian said that there's another one that.
I don't want to hot, but I do want to make a comment about. I think there is another context, another lens to look at this. So there has been a small p progressive movement in this country towards advocating towards national pharmacare, highlighting the issue that Canada is the only developed country with a public health Medicare insurance schema that does not cover prescription drugs, at least for outpatients. And you will note that they had the advocates of that particular momentum focus around the issue of essential medicines, which is about 135 molecules, as opposed to the OHIP plus notional 4,400 molecules. Fundamentally, different approaches to the notion of universalizing access to prescription medications. And the lobby group had an open conference, and they made the mistake of allowing me to register for it and then infiltrate it. It's really a front. It's called the Canadian Health Coalition, or the Health Coalition of Canada. It's a front for the CLC and the trade unions, and Steve Morgan. Some of you, and it was a dry run because they were launching a campaign this fall to call for 135 universal pharmacare for 135 molecules, the so-called Canadianized version of the WHO essential medicines list. And you will notice that Andrea Horwath, the leader of the NDP in Ontario, announced that as part of her election platform for 2018, about 10 days before the provincial budget. Some of you may have noticed that in the BC election sequelae, the 10-page agreement between the NDP and the Greens, the 135 molecules for essential medicines is going to be implemented in the first year of office of the NDP Green political deal. And I think this is absolutely outrageous for anyone with a rare disorder, because we are screwed, glued, and tattooed if the notion of pharmacare reform is built on the premise of covering 135 molecules. All right. So in that context, the fact that the Liberals in Ontario are going in a different direction, I consider that to be good news, notwithstanding there are lots of warts and the need for reform in the existing coverages and access in Ontario, but the possibility of accessing 4,000 molecules is a hell of a lot better than the impossibility of accessing molecules for rare disorders out of a list of 135. That's a mountain we don't need to climb.
Thanks, John. And we're running low on time for the actual webinar. Durhan, do you want to say any final words to close this portion out, and then we're going to invite the next panel up?
Thank you very, very much. And certainly, I think all the comments here are really very much appreciated. I love it when John takes the far view because it makes the rest of us look much more reasonable. So that's this. This is very helpful. Whenever I get to look like the more reasonable person, I think I always enjoy that spot. But really, I do believe that what we want to do is to support the initiative going forward, because the idea of covering all kids cannot be a bad idea whatsoever, whether it's public or private. The idea that we can raise it so that people do not have to worry about losing their coverage because their plan may shift or they hit a maximum, I think is really important. I take everything that Nigel and Chris has said, though, and say, how can we actually make it into recommendations that we can provide to the based on what we hope is really good faith in terms of providing the best possible coverage for our young people, and really making sure then that we're able to leverage this to the hilt. So, I mean, we've heard 485 million. We don't know what that's based on. It may actually cost more than that once we actually scoop in all the other drugs, and we think that would actually be monies that are extremely well spent. So we thank, I think, the minister for opening this up for as an opportunity. We want to put in all the positives that we can in terms of making it the best possible. So thanks again.
Thanks very much, Darhan, and please join me in thanking the panel, and thank you, Katie. Okay, so we're going to leave webinar.